Bueno, ahora sí, buenas noches a todos. Es un gusto saludarlos y acompañarlos hoy. Yo soy Félix Suárez, editor en jefe de Editorial La Molca, y me complace dar la bienvenida a dos autoridades internacionales en el área de la prostodoncia, la implantología y la planificación del tratamiento, los doctores Winston Chee y Saj Jivraj, quienes muy gentilmente aceptaron la invitación de Amolca para dirigirse directamente al público hispanohablante. Doctor Chee, Doctor Jivraj, welcome to this webinar. How are you both?
Good, thank you.
Very well, thank you.
Okay, thank you. It is a pleasure and an honor to have you with us today. Many professionals have registered for this event, and we are pleased to have the opportunity to listen to you and share this time with you. Thank you very much for accepting our invitation. Y bueno, quiero agradecer también a todos los asistentes que nos acompañan en este evento. Espero que puedan apreciar y disfrutar este espacio con nuestros invitados. No quiero extenderme más de la cuenta, pero sí quisiera explicar brevemente cómo será la organización del seminario. Primero leeré una breve semblanza profesional de los doctores Chi y Jivraj. Luego les daré la palabra a nuestros invitados, quienes realizarán su presentación en inglés. Los asistentes pueden activar los subtítulos en esta plataforma desde la opción correspondiente en la barra de herramientas de Zoom y seleccionar el idioma en el que deseen leerlos. Si desean hacer alguna pregunta, pueden escribirla en el chat disponible en esta sala y posteriormente, después del seminario, se las hacemos llegar a los doctores para que puedan responderlas y después las enviaremos las respuestas vía correo electrónico. Entonces, bueno, yo comenzaré presentando al doctor Saj Jivraj, quien obtuvo su título de odontólogo en la Universidad de Manchester, Inglaterra, y completó su formación avanzada en prostodoncia en la Facultad de Odontología Herman Stroh de la Universidad del Sur de California. Ha sido director de la sección de prostodoncia fija y odontología operatoria en la Universidad del Sur de California. También ha publicado numerosos artículos sobre odontología estética e implantología en revistas revisadas por pares y ha impartido conferencias nacionales e internacionales sobre implantología y procedimientos avanzados de prostodoncia. Es coautor del libro Treatment Planning in Implant Dentistry, publicado originalmente por la Asociación Dental Británica y cuya segunda edición en español ha sido publicada por Amolca. Además, es editor del libro Grafted Solution of the Edentulous Patient. Actualmente, el doctor Jivraj es profesor clínico asociado en la Facultad de Odontología Herman Stroh de la Universidad del Sur de California y profesor clínico en el Eastman Dental Institute de Londres. Además, es fundador y codirector del Instituto de Odontología Digital, que forma a odontólogos de todo el mundo en procedimientos de implantes dentales y estética dental. Presento también al doctor Winston Chee, profesor de odontología restauradora en la Facultad de Odontología Herman Ostrow de la Universidad del Sur de California y diplomado por la Junta Americana de Prostodoncia. Ha sido profesor de tiempo completo desde 1986 y cuenta con una amplia trayectoria académica y clínica en el campo de la implantología y la prostodoncia. El doctor Chi ha publicado más de 120 artículos científicos en revistas especializadas y es coautor del libro Planificación del tratamiento en implantología dental. Además, ha impartido numerosas conferencias a nivel nacional e internacional. También ha participado activamente en el ámbito editorial y profesional, formando parte de consejos editoriales, colaborando como revisor en diversas revistas especializadas y desempeñándose como consultor en implantología dental para la Asociación Dental Americana. En la Universidad del Sur de California inició el programa de implantes dentales y lo dirigió durante más de 3 décadas. Asimismo, fue director del programa de formación avanzada en prostodoncia entre 1995 y 2021. Actualmente continúa como docente activo y mantiene una práctica privada especializada en prostodoncia en California. Por último, también digo que también es miembro de varias organizaciones profesionales destacadas como el Colegio Americano de Prostodoncistas, la Asociación Dental Americana y la Academia Americana de Odontología Restauradora. Bueno, ahora sí, cedo la palabra a nuestros invitados, Dr. Chi, Dr. Jivraj. Once again, thank you for being with us today. Somos todo oídos. The floor is yours, doctors.
Okay, I'll go ahead. All right. So the screen is done.
Yes.
Yes.
Okay. So Dr. Jivraj and myself, we agreed that I'm going to discuss the rationale for dental implants, and that's basically a fundamental of our book. And so, with all the people that look at the book, it gives you an idea of how to develop treatment planning for patients, not just a procedure, but how you take care of patients. So we're going to talk to a couple of these topics, and I'll go fairly quickly. And basically talking about non-replacement of missing teeth, shortened dental arch, removable prostheses, fixed partial prostheses, not issues with endo that cause fails, then dental implant placement and preservation of tooth structure. So basically, what we're going to do is conculcate or tell you how we are using implants more and more for taking care of patients, on how some of the earlier cases where we were done when we were making other types of restorations, but with implants is given patients very much better treatment and longevity of the restorations that are placed. So what we're looking for is that long-term outcome for restorations when they're placed. So here it goes. So here we're talking about non-replacement of missing teeth. And when you see patients and you see situations like this is a book that I took out of CASER, and they basically tell you what happens when you have some missing teeth. And the answer for that is that if some people don't have missing teeth in certain situations and they don't really need to have perfect dentitions, that patients can live very well. You know, you don't have to place implants, and you have to decide with the patient and yourself, you know, is this something that's good for the patient? And so when you speak to the patients, it's not automatic that you do something for the patient. You can discuss it with them, and they say that, you know, are you comfortable? Aesthetics, are you good enough? Can you eat? And if the answers are good, you can see in some of these restorations that patients in the long term, you've seen nothing that's been done. So when you look at the two panoracts, one after the other, they can last from 1978 to 1992. If you look at, you can see where the different panoracts are, and patients can do perfectly well there. And so, and then you can see that there are also these people who are very well-known people, and they're basically telling you that you perpetual preservation of what remains is better than meticulous restoration of what is missing. So that means, you know, the less you do, the better. And the better that you can do is the help of using implants. So you don't have to damage other teeth just to make restorations. You know, other people have told you that occlusion, neuromuscular stability can be established as long as they have enough anterior and premolars to be in contact. You don't need to have everything. And Werhag, all these are very famous old-time dentists that I think they are trying to tell everybody that, you know, the best things for patients is to do the least. And that's one thing we like to do when we are treatment planning. We want to do the least we can with the patients, and so they can be healthy and everything can work out. So this is one of the restorations that we've done. This is the maxilla implant is edentulous on the maxilla, and then there are healthy teeth on the mandible, and you can see that we shorten the arch. You don't need to have 14 teeth on each arch. And so when you look at that, aesthetically, everything looks good. And that's all you need for a patient's dentition and patient's aesthetics if they like to be doing these things. And this on the maxilla is a full arch of the maxilla, as you can see. And on the mandible, we just have two implants on the mandibular jaw, right? And here, and so that's another thing that you think of, that you don't have to have a full arch of restorations. You do what is enough for a patient, and they should be comfortable with that, and aesthetics comfortable with that also. When you have removable prostheses, that is dentures and partial dentures, basically when you have teeth, and it preserves all the alveolar bone. And when you don't have teeth, you lose a lot of bone, and you lose all the alveolar bone. All you have is the basal bone left as you can. If you look at this diagram, when you have an implant, when you have a tooth in there, it it holds on to the teeth. It keeps the teeth in there because it causes some force and tension with Sharpie's fibers. And when you do that, you actually keep the bone where it is. And when you look at and you keep a denture for a long time, what you see is that uh, the bone here just keeps shrinking. And you see that's what happens when you look at complete dentures or partial dentures. But when you put implants in them, it's a very interesting thing that when we started to place implants, then you maintain the bone. And that's an important thing. And that's why if you lose these teeth, then having an implant in there is probably better than almost everything else that we are doing for our patients. And here's another example. This is a partial denture that you see here. And this partial denture have these uh, attachments that you see. And these attachments actually cause fracture of these teeth because there's so much force on them. You can see that these have fractured. And you can see that the tooth has fractured and there's actually gutta perca in there, that there's so much fracture that's applied onto partial dentures. So you can see that there are many, many things that can happen. And if they didn't put the partial denture in there, the patient might have been done well without the partial denture and just have a shortened dental arch. Or if they decide that they want to have more occlusal parts in the area, then always consider the implants, because then your decision, like when you're treatment planning, you can have no partial denture, which is better than having implants, is better than having nothing, rather than not having a partial denture because it causes problems, right? So here is an example that you can have. This patient here had a distal extension partial denture on the maxilla. You can see the rest here. When you look on the radiographs here, you can see how much damage that the teeth had because they had rest on the partial denture, and it just caused all these problems here with so much bone loss from these teeth because it was overloaded, right, with the cantilevers. And so when you look here with the same restoration, this is the very early days when we did them. We started with implant placements, as you see, with guided placement. And then these are the restorations that we have without having a RPD anymore. And now they're implant supported, which are certainly things that which are better than having partial dentures. And again, it doesn't cause damage to the other teeth that you can see. And that's one of the most critical things that we're having with treatment planning in implant dentistry, right? And some of these, this particular thing we did was we had this published in one of the journals, as you can see here, right? So here's another one. So for all the people who are watching, this is fairly complex partial denture that we're putting on here. This is some attachments that we have for the anterior part of it. And on the mandible, we have just implants placed, right? And on the maxilla here, you can see the 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 framework on the maxilla and attached to all these areas. When you look at them, which one would anyone think that the long term will be better? Would it be more stable to have implants, or would it be more stable with the partial denture integrated with fixed partial dentures, as you can see here? And what is the answer? I think most people should be answering that if you have a partial denture on the maxilla, then any component of the maxilla, meaning any of these fixed partial dentures, fail or decay collects, then the whole maxillary arch may not be repaired easily and the whole arch may fail. Whereas on the mandible, these segments and implants are just separated, and if there is a problem with one of them, it will not damage the whole arch. But having said that, the implant restorations will be definitely much more stable and have a good longevity compared to have removable prostheses, right? So same, and so this is what we look at from the front. it looks good on the maxilla, but when you go back and look at this again, this whole maxilla might be damaged, and it might not have a long-term outcome, right? So this is patients, and we're reduced. These are things that we've done very early in our cases, and we certainly don't use these types of restorations anymore, right? And this is the same thing, maxilla and the mandible again. So the mandibular arch form is very much more stable than the maxilla, right? So that's the removable partial dentures. Here, the fixed partial dentures supported by teeth. So if you have two perfectly healthy teeth, as you can see here, look at the preparations that have been taken. And so when you prep these teeth and you put a fixed partial denture in there, which would be better? To place two implants in here, or to go ahead and put in a fixed partial denture and significantly weakening the two abutments? So again, that's why implants are important that we can use. This is a fixed partial denture. This is a long-term fixed partial denture, but you can see there's leakage back here, and this is loose and is back here. And when you see this FPD came off with the patient, it actually fractured the anterior abutment. So here you can see the FPD is off, the fixed partial denture is off, and there's half of the fractured restoration that's left in there. So these are all problems, but these are problems before implants were there. Obviously, today we hardly put Pontics in there. We don't want to prepare teeth unless we have to, right? Here's another one. Same thing. We have this restoration there, and instead of so next thing is endodontic teeth that some of the endodontists are not happy, but they actually endodontics works well. But when you don't have any tooth structure, it's not the it's not the endodontists that have a problem. The problem is that there's no structure left. And when you have the missing structure, you can see how they fracture and how these restorations can't host the restoration because they keep breaking. So here is the example that you can see. You can see that the post keeps falling off. And when you look at this, the the root looks pretty healthy, but it just couldn't retain the restoration. So on the restoration, we remove the root, we place the implant, as you can see, and it's without grinding or damaging the adjacent teeth. I mean, that would be the best way to do it. And so here you can see it. And also for this patient, I'm collecting a couple of old images, is that you can see that they've lasted from 2007 to 2016, and the bone levels haven't been lost at any time with these situations. And that's why we are inculcating with everybody and with the book that tells everybody that treatment planning is important, not for an implant, but it's treatment planning for the patient. And then you can decide how implants are when they help treatment planning. Okay, so you can see, and then the most late radiograph that I took was 2021, and you can see everything has held up pretty well, right? This is another one. This is one of the earlier ones that I've had with this patient, and this is one of the early implants placed. And here you have it. It's 28 years later. You can see all the radiographs that have taken place. And again, they have very good bone levels, as you can see. And so those are all important things that are important that you can think of. If you look at this patient, this is a patient with a fixed partial denture, where this is in the old days when we didn't have lithium disilicate, or we didn't have zirconia. They had this restoration where they built everything with porcelain, and all they did was it would keep fracturing and breaking. You can see here it's just a half moon fracture, meaning they keep breaking and chipping. And so the patient wanted to have a new fixed partial denture, and it was a little bit too light. So I took the fixed partial denture off, and I told the patient, it's better to place 2 implants here because these teeth have been severely prepared. And so patient agreed. We went ahead, put a provisional in there, and then had the implants placed, as you can see. And on the implants, we had the 2 implants there, and these were planned to be separated. But the patient was having some pain on the abutments, and I told them it's best to have them extracted because you already have these 2 implants, and so why would you take the chance of a separate crown, right? And so you can see how close the pulp is, and so it's pretty well damaged. And so we extracted it. This is the provisional in there. We put ovate pontic in there, and you can see how it heals up. And this is the provisional, and you can see how it looks in the long term. So everything looks pretty good. And this is the provisional in place. Sorry, the final restoration in place. And these are pontics over this, and these are the implant-supported restorations. So here you can see the provisionals, right? 1996. And then this is the latest radiograph we took, is 2001. And you can see the pontics look well, and the bone levels of the implants look really well. And it holds up much better and is much more stable in the long term. And so here's a couple more x-rays. And so it's interesting that the soft tissue actually creeped up a little bit, as you can see. But after all these years, the patient was very happy with them. So this is the latest radiograph we have at the 2023, and again, very nice conditions with the radiographs, right? So this is one more interesting case that I did. This is a patient with oligodontia, meaning there's a lot of missing teeth here, and a lot of these are primary teeth, meaning baby teeth. And all these restorations are in place. And the treatment was taken in 1995. And so a lot of these are crowned with, you can see these primary teeth. So a lot of those teeth were removed. And you can see these restorations were reconstructed with implants, right? There was 1995 that were done. Here you can see it again, maxilla and mandible. All these are implants. And this is the patient, which is right now as about 20 years ahead. So that was 1995. And those previous radiographs you've seen is now 2022. And you can see it's all taken up with all the implants. And so the other teeth that were healthy, everything looked good. But here you can see all the bone that was implants in the bone was very nicely placed. Okay. And then, of course, the preservation of tooth structure is the one thing that we always want to think about. And here's is a patient that you can see there's a lot of wearing out of these teeth, and you can see that there will be some implants placed here also. And the reason for this is that they had a very high, strong fluorosis, which means the teeth were very weakened and soft. So we actually bonded teeth to these and just had some implants placed on the mandible. So here you can see these teeth. We did some crown lengthening, and then this is a press on to try everything in there. And then the preps that we have minimally, these were bonded with lithium disilicate, right, of restorations that you can see. These are the preps with some crown lengthening. And these are the restorations that were made. And on the mandible, you can see those are implant-supported restorations. And this is the patient with the provisional, and this is the completed restoration. So here you can see the restorations, and everything is pretty well bonded. And the implants are here on the mandible. So this is before, and this is after with the preps. And then the restorations from the lab that we got, and then the completed restorations. Before and after, right? So we increased the vertical dimensions, and then really we just were able to make these restorations. And so that's it. So I've gone pretty quickly to spend the 20 minutes. And basically, it's what we're trying to do is the fundamentals of decision making. In the textbook, for every one of the chapters, we go into more detail. But when you look through the rationale, that means that when you discuss sitting with a patient and telling them, how things should be, what the long-term outcomes are, what is important? Is it the function that's important, or is it the aesthetics that's important? And you need to discuss all those things to be able to take care of the patients as well as possible. Right now, there are some people who just have one track about how they want to make the restorations for the patient, but it's much better to be able to take care of the patient. I'm going to stop share, and I'm going to have Dr. Jivraj to take over. He's going to have a nice case for us to discuss, and then we'll go from there.
Thank you, Dr. Chee. Well, Dr. Jivraj?
Hey, good evening, everyone. I hope everybody is well. Can you see my screen?
Yes, doctor.
Okay, so I hope everybody is well. I hope everybody is enjoying the World Cup. I know you guys are, dying to get to the match later on today, so we're going to try and do this in a timely manner. So essentially what I'm going to try and share with you in the next 20 minutes is just the thought process. We talk about implant dentistry, and implant dentistry isn't about parts. It's not about the specific implant type. It's not about the screws we use. It's really about how we think about implant dentistry. So one of my favorite books is The 7 Habits of Highly Effective People. It was written by an author called Stephen Covey. It's one of the books I read pretty much every year, and I always get some good information to it. And one of the things he talked about, he said that the key to creativity is to begin with the end in mind, with a vision and a blueprint of the desired result. Now, as a prosthodontist in my program, I can't believe, I finished in 2002 and it's been 24 years now. One of the key things at USC that was really ingrained into us was to begin with the end in mind. If we can't visualize the end result, there's no reason to actually start. And to be able to visualize the end result, we have to think of a myriad of factors, a number of factors that could influence the treatment outcome, so that we can give patient options, we can give patients risk benefits, but it's key to be able to visualize the end in mind. So what do I mean by visualizing the end in mind? Let's take, for example, this patient coming in. Patient comes in, there's pus extruding from the implant. We have bone loss. The patient's having pain. You can see that the restoration is not seated so well. And on CT, there's no bone to the buccal of this implant. So when we're visualizing this, we have to think to ourselves, okay, what should the end look like? What should the soft tissue look like? What should the bone that's housing the, how much bone should we have? What should we fabricate the restoration from? And we have to think about all of these factors when we're diagnosing, so that we can come up with an appropriate treatment plan. We can treatment plan differently, but we have to base that treatment plan on the same diagnosis. And in this particular instance, we removed the implant, we placed an additional implant. With a combination of hard and soft tissue grafts, we're able to provide the patient a tooth which actually, an implant or supported restoration, which actually looks like a tooth. So how does this happen? Okay, how does this happen? So one of the quote, Dr. Chee mentioned quite a few quotes in his presentation, but I I do remember one of his, which really has stayed with me for the last 24 years. And he always said to us that an implant in the wrong position always integrates. So if you want a 100% success rate, just place the implants in the wrong position. I'm joking, obviously. But usually when an implant is placed like this, it's really tough to restore. And in a situation like this, you have a number of decisions to make. Do you take the implant out? Do you start over? Do you do hard tissue and soft tissue grafts? Do you rebuild that site again? Or what alternative options are there? What is the patient's smile line? And here, if the implant is integrated, I'm really hoping that the patient's smile line is low. And in this particular instant, the implant was placed in a good amount of bone. The patient's smile line was low. And as much as we hate to do it, we did pink ceramics on a single tooth, and because the patient's smile line was low, we got away with it. This is not obviously an ideal end result. This is dealing with a complication and how we make those decisions. So this is another example of treatment planning. Now, if you look at this panoramic radiograph, there are so many things which we wouldn't do, correct? You look at implants, going into the inferior alveolar nerve. You look at next to the adjacent root surface. You look at different types of implants. You look at endodontically treated teeth with recurrent caries attached to blade implants. There are so many things which are not correct in this particular radiograph. You sometimes wonder how the dentist was thinking about all of these things. And this is exactly what we don't want to do. Implant dentistry is not really about filling spaces. It's not about, okay, there's a space here, let's put an implant in here. If there's a space here, let's put another implant here. It's all about a global approach to treatment planning and how we think about the patient. Are we taking into account their health history? Are we taking into account every possible factor that could influence our outcome? So diagnosis and treatment planning really is the key to success. And in the book, you're going to see each chapter. We outline it with a literature review. We talk about diagnosis, and whether you're thinking about a single tooth or a full arch of treatment, it has to be based on diagnosis and treatment planning. I will give you an example. Today, for example, one of the most popular treatment concepts around the world globally is something called all-on-4, correct? And this is one treatment, and it's indicated in certain situations, but by no means is it a solution for every single edentulous patient, because we know the more implants we place, we're able to segment the restoration, we're able to deal with failures. You have to not get trapped into a process or a specific technique. You have to think about, a lot of factors and diagnose the patient correctly so that you can render appropriate care to the patient. So in this short time we have together, I'm just going to share with you one case. It's a retreatment of a failure. And what we're going to be thinking about is diagnosis. We're going to be thinking about treatment planning. Together with treatment planning, we have to sequence the treatment appropriately. And then we obviously have to execute the treatment with precision so that the outcome is good. So this is a patient that presented to us, very high smile line, thick tissue, has an implant in the upper right central incisor. And the patient has been restored with the porcelain fused to metal restoration, which is cemented on this restoration. So the patient comes in and the patient complains of a bad taste, bleeding, there's mobility from this particular tooth, and the patient's having a lot of discomfort. And the patient's had this restoration done within the last 24 months. So the patient is obviously concerned, obviously having a high smile line. They're concerned about how it's going to look. Is the implant failing? What is actually going on? And the rest of a dentition is immaculate. So we take a cone beam radiograph, and you can see a dehiscence. There's not much bone around the implant. There is actually mobility associated with the implant. And with the pus coming out of the implant, we can be safe to say that this implant is really not in the best shape and is failing. And we have to make decisions in regards to what our next steps are going to be. Now, we have inflammation, we have bony dehiscence, we have we have to question the soft tissue quality. The implant has been placed very shallow. And more importantly, the patient has a very high smile line. So we really don't have much room for error here. On top of that, the patient gives us some requirements. The patient does not want to wear a removable appliance. The patient is a local celebrity, and what compounds all of that, her father is a very prominent lawyer in town. So at this point, I'm thinking, do I really want to treat this patient? But yeah, she is a friend of one of our patients, so we do decide to go ahead and treat this patient. But these are all the factors you might want to think twice about before you treat this patient. So when we're talking about decision making, there are two sets of factors we're thinking about. We're thinking about diagnostic factors, and then we're thinking about the implant factors. When we talk about diagnostic factors, we are looking at the smile line. Is it a high smile line, low smile line? With this particular patient being a high smile line, obviously it's going to be much more challenging. We have to think about the tooth or the implant position. We have to think about how thick the tissue is. What is the biotype of the tissue? What is the tooth shape? And how much bone and soft tissue do we have to work with? From an implant perspective, we're thinking about how do we place the implant? When do we place the implant? What's the diameter of the implant we're going to place? Do we utilize platform switching? What is the abutment material that we're going to utilize? And if we're going to do this cement or screw retain, both of them having advantages and disadvantages. So the outcome really is based on an appropriate diagnosis, treatment plan, treatment sequencing, and then the execution of treatment. So let's look at how we decided to treat this patient. So the patient will not wear a removable, right? That is key in guiding this particular treatment plan. So we have to start thinking about how we're going to transition the patient. And we have to transition the patient when we remove the implant. We have to transition the patient when we're placing the implant. And then we have to transition the patient on implant integration. So there are 3 phases that we need to think about. Now, our options are an interim partial denture, an Essex appliance, both of them being removable, and the patient has already told us that they are unwilling to wear a removable appliance. The next option we could do is we could take out the implant, immediately place, and immediately restore. My suggestion to you in this particular scenario where the patient has a history of implant failure and a high smile line, immediate placement and restoration is not something that I would be thinking about personally. And as I said, the high smile dictates this. One of the most, I would say, forgotten transitional appliances that we use is a resin bonded bridge. And yes, it's a resin bonded, it's a cast metal resin bonded bridge. And these serve as an invaluable tool when the occlusion allows to transition this type of patients. So when we're sequencing treatment, the considerations that we have is that we obviously have lack of bone and soft tissue. So we need to think about removing the implant, curetting the site, cleaning it up, allograft and a soft tissue graft so that we have an abundance of soft tissue. We have to be able to place the implant correctly, and 3D positioning of that implant is key to a successful outcome. And in the book on the chapter on aesthetic implant dentistry, we go through a number of factors, whether it's an internal connection, external connection, the type of implant it is, how we should be placing the implant, how much bone we should have buccal to the implant. There's a number of factors that we need to think about, which we don't really have enough time to go into in this presentation. Once the implant is integrated, we need to think about soft tissue development because we want that implant restoration to look like the adjacent tooth. And with it being a central incisor, the pressure to produce has become a lot more heightened. And then we go to the definitive restoration. So the first thing we do, you can scan, you can make a conventional impression, have a model made, and do a traditional resin bonded restoration, which has metal wings. In this scenario, we do use 2 wings. Usually, if we're using a resin bonded fixed partial denture as a definitive restoration, we use 1 wing. But in this particular instance, I want to ensure that the patient can maintain this provisional restoration whilst we're doing our surgical phase. So this is the day of implant removal. You can see the trajectory of the implant that had been placed. So we back this implant out, we clean everything up. We do an allograft, and then we punch the tuberosity area, and we provide the patient with a soft tissue graft. And on the same day, as our promise to the patient, we didn't transition the patient in a removable appliance. We provided the patient with a resin-bonded fixed partial denture. And this definitely doesn't compress the tissue. We want that tissue to mature, right? So this is a really nice way of being able to transition the patient. And when you're bonding this resin bonded fixed partial denture, we're using anaerobic cements like Panavia. That would be one of the cements that we use. And you don't really have to have super attention to detail because we want to be able to take this off at some point. So this is our three-week post-op, and the patient's healing up quite nicely. We have the patient keep the area clean, and we're just waiting for the bone to integrate. We're waiting for the soft tissue to mature. So once that has happened, the next thing that we need to think about is implant placement. And implant placement can be guided, can be non-guided, can be a conventional surgical guide, but the principles remain the same. Depending on the type of tooth you are replacing, the goal of aesthetic implant dentistry is to have as much bone buckled to the implant as possible, and the implant needs to be placed deep enough so that we have a nice transition zone so that we can provide the patient with an aesthetic looking restoration. When you're using an internal connection implant, that implant has to be placed slightly deeper because the emergence profile starts from within the implant and is a little bit deeper. And I think in most situations today, I think most people are using internal connection implants for implants in the aesthetic zone. So we're thinking about 3D position. We're thinking about if the restoration is going to be screw retained or cemented. We need to think about our incision design. This is a central incisor. We need to think about the diameter of the implant. Now, just because we have a lot of bone doesn't mean that we place the widest implant possible. It's better to have less titanium and more bone. It becomes a biologically more stable situation. And then also we need to think about the type of healing abutment that we're going to place. So we try to place the implant very minimally invasively. We ensure that the implant is placed so that we can have a transition zone that replicates the adjacent tooth so that we can position the implant and the restoration so that the gingival margin, the free gingival margin, is similar to the adjacent tooth. So the implant is placed and we place a narrow healing abutment. The reason for the narrow healing abutment is that we want to ensure that there's an abundance of soft tissue so that we can sculpt it later down the line. We always want more rather than less soft tissue. So this is the patient, a few months down the line, and you can see we've got essentially too much tissue. And sometimes this can be quite difficult when we're making impressions, when we're trying to sculpt the tissue. It can be a little bit uncomfortable for the patient. But I'd rather be dealing with this type of situation than a lack of soft tissue. So we make an impression, and you can see over here that the trajectory of the implant is such that it's in a cemented restoration position. So we're going to need to sculpt the tissue, and it doesn't mean that we're going to do a cemented restoration. There are many options that we can think about, but the trajectory of the implant is where the bone is. The trajectory of the implant in the anterior maxilla is such usually that the implant is placed in this position, and we can use techniques such as a dynamic abutment or angulated screw channel to be able to transition this restoration into a screw retained position. Our next phase is soft tissue development, and we're fabricating a provisional so that we can guide the tissue to exactly where we want it to be. And when you are screwing in this restoration, you have to do it very carefully, slowly, a little bit at a time. Tissue blanches a little bit more, tissue blanches a little bit more, and sometimes you have to numb the patient for this particular. It can be a little bit uncomfortable for the patient. And once we have the implant restoration in place, we just sit and wait. Now, how long do you wait for the provisional restoration? And the answer to that, it really depends, right? The literature will say 2 to 6 months. When you've grafted the area, we need maturation of the tissue. Sometimes you may get tissue creep. So I would say as long as reasonably possible. And then the question becomes, we have to transfer the position of the tissue to our laboratory technician so that a laboratory technician can provide us a restoration which mimics the adjacent tooth. And this can be done with a conventional impression coping, with a customized impression coping, or we can even today, we're scanning, and we can scan the soft tissue also and transmit the information that way. Now, the decision that we need to make, are we going to do a screw retained restoration or a cemented restoration? And in the textbook, Dr. Chee does an amazing chapter on how we make that decision. We can't be 100% screw retained. There are some situations where we have to cement, but we have to think about those situations when we're cementing. Obviously, with screw retained restoration, we have a scenario that it's retrievable, which is always a great thing. In this scenario, we're going to need to use either an angulated screw channel or a dynamic abutment. But the other thing that you have to think about is today, when we're using zirconia restorations and we're using tie bases, we're cementing the tie base within the zirconia abutment. And sometimes these tie bases, when they're angulated, can be short. Long term, this could end up with a problem in regards to the zirconia de-cementing from the tie base. So these are things that you need to think about. If you are choosing to do a cemented restoration, obviously we have to sculpt the tissue so that we can accurately place the cement margin. We do not want that cement margin to be deep. We want that cement margin to have a scallop similar to a CEJ. So we want it to have anatomical contours. So we utilized an angulated screw channel, and we ensured that we had polished zirconia subgingivally so we can take advantage of the hemidesmosomal attachment to the tissue. We have to pay attention to the emergence profile, the subcritical contour as it's been talked about in the literature. And this is our definitive restoration. And I think after having gone through implant removal, soft tissue, implant placement, I think we ended up with a reasonable result for the patient from where we started. And we actually even got back a little bit more tissue. The tissue, and that could be due to implant placement, grafting, could be tissue creep. But I think we did a reasonable job going through the sequence of treatment. Now, the reason we could have done that is we spent a lot of time at the outset on the diagnosis, looking to see what is missing, what we need to do, how we're going to transition the patient, how much hard tissue do we need, what is the three-dimensional implant position that is required to achieve an aesthetic restoration. So I hope in that short 20 minutes you got some information. We go into a lot more detail in the book, and I'm going to finish with a quote here. And it's learning and innovation go hand in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. This is by William Pollard. And essentially what he's telling us is that things are changing. I remember when Dr. Chee and I wrote the first edition of this book, and it came out in 2006. The second edition, we had almost 10 times the amount of information. Things that change in terms of technology and abutments and implant design, and all of these things have changed, but one constant that remained was diagnosis and treatment planning based on science so that we can render appropriate care to the patient. So with that said, I want to wish Colombia good luck for this evening. I hope you guys win. Maybe Colombia will play England, and then you'll find out how it is to lose. But never mind. Thank you very much. This is my details should you want to get in contact with me. Thank you for your time and attention.
Thank you, Dr. Jivraj. Thank you, Dr. Chee, for your presentations. I think it was very valuable for the attendees and offers an important perspective on how you approach treatment planning in implant dentistry. Thank you, doctors. And I hope Colombia wins today.
I hope they win too.
I would like to ask a few questions that came to mind while I was working on the Spanish edition of your book. You mentioned some of these topics during your presentation, but I would still like to ask these questions. The first question is the following. How important is the cause of tooth loss in the treatment planning process? For example, does the approach changes when teeth were lost because of caries versus periodontal disease?
I can have something to say with that. The great thing with implants, when you put them in there with caries, then there's no calcification that can happen. So for those patients, it's pretty easy for them. Now, when you have periodontitis, there's a problem because you can extract the tooth, but the problem is the bacteria and everything else is going to stay in there, and you may have a much higher chance of the problems that you have with implants. So when you have that, you need really good hygiene for home and professional hygiene once those implants are placed. So when you have periodontitis, we also have peri-implantitis now, and that's usually from a history of patients who have periodontal disease.
Okay, doctor. I don't know if Dr. Jivraj wants to talk about or answer the question, or I'm going to make the next question.
No, go for the next question. That was answered very well. So,
okay. The next question is the following. In your experience, what are some of the most common mistakes clinicians make when planning implant treatment in general?
So I would say some of the most common mistakes really is not gathering enough information. I think dentists, when they're starting out to do implant dentistry, they're just thinking about the bone. They're just thinking about, okay, how many implants can I place? But they're not thinking about what the end result should be. The reality is the patient really doesn't care too much about the implant. They care about the final outcome, which is going to be the tooth. So we're planning backwards. So it's not a space filling exercise, rather a diagnosis and treatment planning exercise. And there are some situations where there are spaces and we don't even treatment plan implants, and you've got to know when to do that.
Okay, thank you, doctor. My third question is related to the answer, but some is related to the aesthetic outcomes, because many patients are highly concerned and sometimes impatient too about aesthetics. What general recommendations would you give implantologists for communicating with patients who has very high aesthetic expectations?
Dr. Chee, do you want to take that?
Well, it's difficult to talk to a patient unless you can, how shall I say, where the amount of where the lip movement is, where the smile line is, how many areas are there where the teeth have moved, how many teeth have been damaged. I mean, there's so many things that go along. You have to keep, how shall I put it this way? For when our residents were in our program, when we have our treatment planning, what we do is, hey, you know what? The person who knows the most factors to think about is going to be the person who's going to have the best treatment planning. So you can't just look at one thing. You have to look at the patient. What is their age? What's the situation of the teeth? What is is the patient have periodontitis or have a lot of decay? Do they have high function, meaning they grind their teeth? What is the soft tissue? What is the type of soft tissue you have? And it goes on and on and on. And so you have to think about all those things just to ask somebody, can you tell us what to do now? And we never did that when we are one of the unusual uh, programs in prosthetics at USC. I was a program director there for 30 years. Then I stepped down and we have another program director now. And basically, at treatment planning, when they actually discuss it, we don't tell them anything. We just tell them, you need to go and find out what has to be done for the patient, and then we'll talk. And so what happens is in our program, which is 3 years, we have two treatment plans every week. And so it's 2 hours every week. One program is only for the advanced prosthodontics. The second program is with other people who are in there. So periodontal people are there, prosthodontics people are there, oral surgeons people are there. And we have those discussions. And in that treatment plan, we have at least 3 faculty members who are in there with the with all the other residents. And so that's how you figure it out. That question that you asked me would be very difficult to answer from one person.
I'm going to just
Such.
say one thing. So the more I do this, the more I like to keep teeth, because the aesthetic outcome of a tooth is way better than an implant. Whether you're dealing with a single tooth or whether you're dealing with a full arch, keeping the tooth is going to yield the best aesthetic outcome. And we try our best to keep teeth if at all possible. Unfortunately, today, there are too many teeth being removed in favor of implants, and the patients are not told that implants can also have problems. So if somebody comes in with high aesthetic demand, say a central incisor, I'm looking at the root length, I'm looking at the bony support, I'm looking at the soft tissue, I'm looking to see how many back teeth the patient has for posterior support. These are all the things that I'm going to look at, and I'm going to try my best to try and save the tooth somehow, because I know my aesthetic outcome is going to be way better than the implant, and it'll be more long-term too.
Okay, doctor. Thank you. Thank you, doctors, for your answers. The last question is related to the second edition of your book, because there is a significant time gap between the first edition and the current one. From your perspective, what are the most important differences between the first edition and the second edition?
It's a mistake that I made because they asked us to uh, have the second edition, and that was quite a headache for us. So we did the second edition with the idea that we'll just have a few couple of new pictures in there, and we'll have the first edition, and it would be easy. Well, guess what? The first edition is about, I think, 150 pages, and this one is about 600 pages. And Dr. Jivraj and myself, we both learned a lot together. And if you look on my uh, on my acknowledgement down there, I told Dr. Jivraj, because he's much younger than I am, that he can have somebody else to co-edit number 3 because I'm out.
Okay. I got the second edition here. There's more than 150 pages.
Oh yeah, for sure.
Yeah. Thank you, doctors, really for your time. It was an honor to have you with us in this webinar today. Fue un gran honor, de verdad, tener a los doctores Chee y Jivraj, autores de la obra Planificación del tratamiento en implantología dental, cuya segunda edición ha sido publicada por Editorial Amolca. Si quieren obtener más información, pueden escanear el código QR que está en la pantalla. Hay una oferta disponible por el libro, la promoción varía en cada país y es una oferta exclusiva vía atención directa por WhatsApp y válida por 48 horas. Dr. Chi, Dr. Jivraj, would you like to add anything before we close the webinar?
No, thank you for your time in arranging this. We appreciate it. As I said, in regards to the book, it's something which it's a distillation, I think, of many, many, many years of teaching. Dr. Chi here was our program director, and he's been a program director at USC for many, many years. And we've always thought about how can we take this information and put it into a format which is science-based, based on diagnosis, and also provides treatment execution. So what you're going to see in this book is alumni from our program that have contributed, and they've all become leaders in their own right. So each chapter is written by somebody who really knows that material very, very well. And it goes everywhere from rationale, single tooth, laboratory work, full mouth rehabilitation, and even how to deal with failure. So every single, aspect has been covered. I really hope you folks enjoy it.
Yeah. And also, I will have to say that when we had no implants in the university, I started in there in 1987 from zero. And up to now, I think we have a pretty good program in our university. And, it was just And I think it was, and the good thing is that I think we are taking good care of the patients and not doing any treatment that's not needed. And that's one of the biggest problems we see in some cultures, that all they want to do is put implants in there. But I think it's very important for the patient. And that's why the book tells us that implant for treatment planning is one of the most important things for implants, rather than just putting implants any empty space you have, or they make empty space you have just to place implants.
Okay, okay. My microphone was off. But I would like to thank you, doctors, for your time. Y bueno, no me queda más que despedirme realmente a todos los asistentes. Si hicieron alguna pregunta, los doctores van muy cordialmente a responderlas y luego las pasaremos a su correo electrónico con las respuestas de los doctores. De verdad, muchísimas gracias a todos. Y bueno, esperemos que gane Colombia. I hope Colombia wins today.
They
Eh,
will. They will.
sí, sí. Bueno, buenas noches a todos y que estén muy bien.